Good afternoon. Welcome to today's meeting of the Adults and Communities Overview and Scrutiny Committee, which is taking place at County Hall in Glenfield, though some officers will be joining via Microsoft Teams. Mr. Richardson had to send his apologies, so I'll be chairing today's meeting. I also have apologies from Mr. Hills and Mrs. Wright. I would like to remind everyone present that the meeting is being broadcast live via the County Council's website and will also be available for viewing after the meeting. Can everyone please switch their microphones on when speaking and turn off when finished speaking? Thank you. Item 1. Minutes of the meeting held on the 24th of January 2022. I propose that the minutes of the meeting held on the 24th of January 2022 are taken as read, confirmed and signed. Do all agree? Thank you. Agenda item 2, question time. I have received no questions from members of the public. Agenda item 3, questions asked by members under Standing Orders 7(3) and 7(5). I have received no questions from members. To advise of any other items which the Chairman has decided to take as urgent elsewhere on the agenda. I have not been notified of any urgent items. Declarations of interest in respect of items on the agenda. Does any member have any interest they wish to declare? None, thank you. Item 6, declarations of the party whip in accordance with the Overview and Scrutiny Procedure Rule 16. Do members have any declarations? None, thank you. Presentation of petitions under Standing Order 35. No petitions have been received. Agenda item 8. Item 8 on today's agenda is a presentation on care technology transformation, as set out on pages 13 to 16 of the agenda pack, and which will also be displayed on the screen. The director will introduce this item before handing it over to Nigel Thomas, Assistant Director, Mark Allen from Hampshire County Council, and Luke Mayer from PA Consulting Group to present. Thank you.
Thank you, Chair. I'm going to be very brief on this one. I'm going to hand straight over to Nigel, if that's okay.
Thank you, John, and good afternoon, everybody. So have you heard, we've got colleagues from Hampshire County Council and their commercial partner PA this afternoon, and what we wanted to do was really give you an update on the emerging care technology service that we'll be introducing across the department in April. I'll give a broad overview. First of all, I'll set the context and then hand over to Mark from Hampshire, Luke from PA to talk through the features of what we're setting up, and also to draw on some of Hampshire's experience as a leader and innovator in the use of technology across social care. So just a reminder to people in this context, when we're talking about technology and care technology here, we're really talking about technology that can be supplied or installed in people's homes to enable them to live independently and help them achieve their intended outcomes. I think it's really important to emphasise right from the start that this isn't a technology for technology's sake project. It really has to meet people's outcomes as part of a feature of the service. And you may be aware that the recent care reform white paper features a proposal to accelerate the use of technology in social care because of the benefits it can bring people who are eligible for services, not only in helping them achieve their outcomes, but also to avoid or delay more costly interventions later through a care pathway. Now in Leicestershire, we do have an assistive technology team, and that up until now has offered a traditional type of service delivered through the AT team, which delivers aspects of tech assistance, but it's not rooted in an overall approach to care assessment that really does place technology at the centre of that process. So back in 2020, we engaged with Hampshire who's a leader in this field and have been for a number of years, to undertake a diagnostic of our services and outlined a case for transforming our approach to the use of care technology. We developed a business case last year, and that proposed a remodelling of the existing assistive technology team to mainstream tech across social care and encourage practitioners to place it as part of a first offer. Hampshire now are our strategic partner, and with PA, their commercial partner, our ambition really is to remodel the assistive technology team into a care technology service that will be embedded as part of the social care offer. That team has been remodelled. We're really in the mobilisation phase of that service. So I'm going to hand over to Luke to talk through some of what that transformed approach will be. So hopefully Luke's on the call. I can see him there.
Thanks, Nigel. Hi, everyone. So the as Nigel said, the kind of the core aims of the transformation are to position care technology as part of the core tool set of social workers and other practitioners in the health and care system, so that it becomes one of those things that gets reached for first, if you like, when practitioners are thinking about how you support and help residents. So to do that, there'll be a big program of cultural change, which we've already started, which engages with practitioners across the system and within the council to begin with, and we've an aim to anybody that will be able to make a referral into the service will get training by the time the cultural change program is over, and then there'll be a series of refresher sessions to make sure we keep in touch with all of those people that are going to be using the service for the benefit of their residents. As you'd expect with this type of service, there'll be a detailed quality assurance framework to make sure things are going as they are. And one of the things that we bring in as part of the service is a very robust approach to measuring and managing the benefits that the service produces, and that's benefits and outcomes for people in a kind of real life sense, but also financial benefits to the council. And so the model that we put in place will have you can drill down to the benefits received from each individual person that uses the service. So everything is trackable right down to individual people, so that the numbers that get produced, people can have confidence in. In terms of the benefits from the service for people, there are kind of really three categories. One, and most importantly, improved outcomes for people with care and who will be receiving the service. And really, we're aiming to help people live for as long as possible, as independently as possible, and manage their health as well as they can. We've got a target to reach 1,400 people in the first year of the service, and then similar targets beyond that in years 2 and 3 of the service. So it will continue to grow with an increasing number of users on it. There'll be outcomes for care practitioners, so those practitioners that we talked about within the council, within hospitals and so forth. So a more responsive understanding of benefits and a greater understanding of what technology can achieve for the people that they're looking to help. And then, as I've already talked about, a set of financial benefits, financial outcomes for the council. And the modelling for this service is that there'll be a net benefit that is in the region of £5 million once costs are taken into consideration by 2025-26. Throughout the service, the most important thing of it is the impact that it has on people, and so we've included one case study on this slide, which is, the name's changed and it's anonymised, but is from one of our other services where Mr. Bennett was. He has long-term epilepsy, and prior to having an increase in blackouts and seizures, was working within a hospital, and then started having those blackouts and seizures, and that caused a lot of stress and anxiety about being able to access the community, travel to work, basically carry on with his life as it was day to day. And with the introduction of a small amount of personal equipment, really, of CT in terms of personal alarm, a GPS tracker that clipped to his belt, that really gave him a sense of security and a sense of reassurance that he could continue to do what he had been doing and still manage the risk of these increased seasons and blackouts. So he returned to work having had a brief gap in it, and so as a result, that introduction of technology avoided the need for domiciliary care. And that's just one example. The main outcome of that is the fact that Mr. Bennett could carry on with his life as he wanted to. Another important outcome of that was the fact that the council saved on the cost of that care. In terms of the governance of the service, as you'd expect, we've got a range of work streams which are involved in mobilisation now. We're reporting into a monthly service operations group who are scrutinising all of the key policies, decisions that we're making as we go through this transformation. And then that reports up to a steering group who are similarly reviewing all of that material and checking that we're on track and doing things as we need to. If we go on to the next slide, and I'm handing over to Mark at this point.
Thanks very much, Luke. Good afternoon, everyone. One of the things that we've tried to do throughout the period of working with Nigel and John and other colleagues is to bring the learning that we've had over the last probably 8 or 9 years within Hampshire, so that there's both a sense of not reinventing the wheel and actually building on practice elsewhere, but also bringing some of those real examples of how we've been able to transform elements of our social care offer using technology and what that's meant for us in practice as an organisation. So this slide is just a real very quick run through of some of the sort of headline figures that have been important for us to be able to demonstrate clearly over the years. I won't start with the money, but I'll start over in terms of the numbers of service users we've got. So this slide is saying 13,000. We've actually just done a re-look at that, and it's nearer to 14,000. Those are all people with social care needs, or 90% of them, and that other 10% are people who have had a diagnosis of dementia. So they're all people who have got very clear needs who we are meeting through using technology, and that's combined with other forms of care, but it can also be just standalone equipment that people are using to meet their needs. And all of these individuals will be living independently within the community. The area of training that we've engaged in, as Luke said, that's a key part of the programme that is what we're working with your colleagues on. We've trained over 2,000 social care and health professionals over the last 7 or 8 years. That's been an ongoing rolling programme of training, partly in response to natural turnover, but we've run a programme of train, retrain and continue to train because things develop and circumstances change. What we've seen is that because we take a very clear approach to meeting people's needs in a fairly bespoke ways, as bespoke as we possibly can, people feel that their needs are met very well. So you'll see there that 93% of the people that we offer services to feel their safety and security is increased, and 98% of people using the service would recommend it to others. And also our practitioners are very supportive of the service. It's very embedded in their own practice. And it means that actually what we get is a very good view of the service, so that people say 9 out of 10 would be saying it's good or very good and is achieving outcomes. In tandem with this, and again, it's another element that Luke mentioned, but where we've put in place a system of benefits realisation, so we measure that constantly throughout the work that we do. But it's not just working with us. We work alongside our CCG colleagues in the police, for example, where we offer services that complement the activities that they do. We're able to show where those benefits are driving out. And lastly, the element of the financial part, we've been able to demonstrate net savings or net cost efficiencies over that period of time, which for us have amounted to over £14 million in the period we've been working together, and those are verified by our own financial teams and our business intelligence teams. But beyond that, we've been able to, because we've got this very solid foundation of delivering a very core area of work, we have been able to look at other types of technologies and how they embed in the system that we've got in social care. So we've got a program of using robotics to support carers deliver care. We were the first local authority to really do anything at scale around using the Amazon Echo, and we developed during the shielding period during COVID, and for those shielding, an automated call service that actually managed our approach to contacting people who are shielding. And we've done a lot of work around our children's services as well. So as you can see, there's a lot of potential for future work for care technology in Leicestershire. So we're working through currently as part of the mobilisation process of trying to address some of those very key questions for Leicestershire. So what are the challenges that you as an organisation are facing in terms of adult social care? What are the opportunities out there for technology to help unlock different approaches to delivering care? What system partners could care technology help with and engage with to broaden the service impact? And what are the strengths of you as an organisation that can actually help maximise the use of technology, which there will be masses, and we've already been really pleasantly surprised and encouraged by the engagement of the whole of the workforce that we've been in touch with about their willingness to engage in this. So I'll hand back to Luke, who's going to take you through a final slide.
Thanks, Mark. So this slide gives a sense of some of the work streams that are set up and delivering the transformation activity at the moment. And each of these work streams has a combination of people working on it. So people from Leicestershire County Council in terms of programme team, but also practitioners involved in each of the work streams, and then people from Hampshire and PA respectively split across these different work streams depending on their focus. I'm not going to go through, I'm sure people have had a chance to read it or will have. I'm not going to go through each one of them, but to give you a sense, each of the work streams is progressing well, and we're at the moment on track for successfully launching the reform service in April. And so I'll touch on the service redesign workstream just because I think it gives a really good flavour of the work we're doing and the input that we're receiving. So that the purpose of the service redesign is really to look at the care technology pathway and design the way that works within the council and gets referrals from outside of the council, and designs all of the bits and pieces that underpin that in terms of policies and procedures and the detail. So far it's been a fantastic series of engagements that we've had with this. So we've had more than 40 staff from across adult social care in Leicestershire get involved in this, as well as colleagues from BI and systems teams and so forth, who have taken part in a series of workshops co-designing what the new pathway looks like. And that process started from key service design questions and then moved through into detail from there. And there's as an example, that's produced things like a brand new co-produced referral form that all practitioners will use to refer people onto the service. That will be embedded within LAS and will pull through most of the information that needs. So that at the moment, we're trying to make the aim is to make that referral process as intuitive and easy to use for practitioners as possible. And at the moment, we think that from start to finish, a practitioner using that and referring somebody into the service will take 5 minutes for them. So something that's achievable within their kind of day-to-day practice. The final one around learning and development. So we've recruited a champions network. There are 8 care technology champions now across the council, and we've delivered a series of training events to them. They will now go on and cascade information sessions out to practitioners across the county, so that it's, rather than us being in front of people telling everybody about the benefits of care technology, it's practitioners themselves that are going to be leading training sessions with the rest of their colleagues, with our support and materials that we're developing for them. I'll stop there, but very happy to answer questions on any of the other work streams or the other content of the slides that you've seen.
Thank you very much for the presentation. I should now open this up for members' questions. I believe, Mr. Champion, you would like have a question to ask?
Thank you, Chair. It's probably a question for Mark, actually, but it's on this page with the benefits and service development in Hampshire so far. Figures look good. So 9 out of 10 social workers say good, very good, but that obviously still means that's 10% that don't think it's good and very good. I wondered what your processes are to go back over that and see where things aren't quite working right, etc. Same as with you, 93% of people have increased security. That's still 7% that don't feel that. So do you have some processes you go through to see where things are going wrong or misunderstood or something like that?
Very good questions. I think for us, it's a continual process of learning. So whilst those figures are exceptional, and there's probably very few services that would meet those sorts of levels of satisfaction, you're right, they're not 100%. So what we would do in terms of the service users, particularly service users, where there aren't people who feel completely satisfied with the service, we talk to them, we'll gather information about what it is that's happened. Sometimes there are things out of our control, so a lot of the technology we use relies on the sort of the public telephony system. That can have issues which can actually disrupt services for people. But some people, we don't get it right all the time in terms of meeting their particular needs. So we will talk to them. So a good example of what we've done over February is we offer services to people with learning disability in services. So we've actually gone out and proactively interviewed 380 individuals and their support workers to find out how the service is delivering, what we could do that's better. And then that's built into the process of developing service further. It's never a standstill type of service. Equally with our staff, I think we are always attempting to meet the needs of the system, the internal system. That's not always possible, but we do try and learn as quickly as we've got. So another example where we use our own skills to improve things is I've got a senior practitioner who's a social worker who's seconded to Luke's colleagues in Hampshire and works with them on the training, but also works with them on the practice side, so that where we can see where practice is maybe not meeting particular needs in certain areas, where we can start to address that. And it means that somebody who uses the language of the people who are using the service can have that conversation. It's not a bureaucrat like myself, it's actually a practitioner that has those conversations.
Thank you, Mark.
Answer your question, Mr. Champion. Ms. Broadley, I believe you have a question.
Thank you, Chair. The figures look exceptionally good. When you've put this to people about going with technology rather than the old system, have you had many people decline this system? And if so, what are their reasons for declining to use it? Is it because they don't have the knowledge of technology on how to use it? And if that is the case, is there something in place to assist them?
Could I answer that first and then maybe ask Luke to comment? I think one of the things that we've done is we've learned over the years. I think where we first started, there was a degree of resistance. And I think the world, in terms of digital services and using technology to support people, has changed very significantly, certainly in the last 2 years over the COVID period. I think we found initially where there was resistance, so we were talking back in 2013 probably, resistance from professionals and from individuals, where there was a degree of suspicion about, as you said, using technology to replace other things. Well, it's not really like that. It's actually technology supports other types of activity as well. What we've learned over the years is the conversation we have with people is important. The way the service is delivered in that individual's home is important. The conversations that our telecare assessors or technology assessors have with those individuals is really important. And so this isn't a service. This is how it's delivered in Hampshire, and now the implementation is going forward in Leicestershire. Those conversations, it isn't a service that just dumps a load of technology in somebody's home and leaves. It's actually an assessor goes to the home, talks to the individual about their needs, their environment, and actually starts to install technology that's appropriate to those personal circumstances. So all of these different things that we're doing helps to actually make it more relevant to those individuals, so that they can see how that technology is helping them in certain ways and complementing the other types of care and support that they may be receiving. So it's not perfect, as we said in the previous one, but there are lots of things we've learned over the years that we can do to support people to understand how technology helps them. Inevitably, there are always some people who say, no, don't want that. And then we need to think about what types of support and care that they can be provided with that meet their needs. I don't know if you've got anything to add, Luke.
Thanks, Mark. What Mark said about conversations with people is crucial. So, and the way those conversations are conducted. So if somebody turns up to a user's home and says, would you like some care technology? You're unlikely to get a kind of immediate and enthusiastic yes to that question. If somebody's gone in, had a conversation, talked about somebody's needs and what somebody, the challenges somebody has, and then starts to suggest solutions that are about the kind of answer rather than about the piece of kit, then you tend to get a much warmer response. And all of the part of the training that we're doing with the team in Leicestershire is around those conversations and kind of personalisation of those conversations. So that's one thing. And I should say the team in Leicestershire have been doing this for a long time as well. So we'll be skilled in some of that already. The other thing is, people are often keen to have the technology because it adds to a sense of independence and managing their lives, themselves, rather than having somebody come round, that might be perceived to be kind of checking on them. So it feels much more like people are managing their own life, continuing to live independently as they choose to, rather than being constrained. So, for example, if there's something where we can use a piece of technology with a GPS tracker that allows somebody to carry on going and accessing the community and the things that they enjoy doing and feel safe to do that, that if it's presented in the right way can be welcomed, rather than somebody being kind of nervously managed and kind of shut in the house a little bit more if relatives or carers feel that there's a danger to them wandering off.
Thank you for that. Does that answer your question?
Yes, thank you, Chair. I wasn't being negative. I don't know what you think I was. I think it's a fantastic thing. It was just the fact that I have a 92-year-old mother who, at the moment, doesn't have any care. She looks after herself and does everything. But if somebody walked in and said to her, we're going to fit this and we can do that, then she would be absolutely horrified. So I'm pleased to hear that you go about the solution before the technology. Thank you.
Mr. Mayor, you have a question, please?
I'm just going to follow on from that. I think what you said was correct at the end. The technology has to follow the demand for it and the base need for the demographics. So I just always look at my mum in this kind of scenario. She's 70 this year, and hopefully not for many more years, she's not going to need this kind of help, but she may do. It might be next month, it might be next year, it might be the year after. But how, a lady of ethnic background who is not very good with tech, how is she going to get that care, or how is she going to get that kind of care once we start shifting over? It's not going to be everything all at once, but say 3 years, 4 years, 5 years down the line, she needs help and access, and her care needs grow. How would she access it? And that's what I wanted to ask is, what's the development plan here? Is it like 1 year, this is step one, in 3 years time it will be step two, and what will be the work we do with the people that we can't actually access straight away? Will there be like one-to-one for them, or maybe a group session where they can go in and have a look at it? Because once like Zoom this time round, a lot of people never use Zoom. My mum uses Zoom now, so it's just, but they just need to be shown it. And so how are we going to do that? It might be a bit of an upfront cost, but I think the payback will be massive later on. And to echo that, I actually think we're going in the right direction. So this kind of thing coming to us, you're not going to find much friction or pushback here, but I just want to make sure it's implemented and nobody's left behind. Thank you.
Mark, shall I start and then you can chip in after that? The so thank you for that. You're right to say that there's a development plan for the service. So when we start, we're concentrating on really getting the service up and running with a remodel pathway and underpinning systems and practice for that. And the main cohort for that is elderly and frail. Over time and into the contract of this, we're PA in Hampshire. Part of our role is to help the council think about strategic growth of the service, and that's starting to look at new cohorts of potential users that might benefit from the service. So, as a result, Mark will be able to talk about some of the new pathways and new cohorts that we've collectively looked at and work with in Hampshire. But that strategic growth plan will develop with the council, and the idea is that there'll be 2 new cohorts each year that will develop the service pathway for. So that might be, for instance, an early dementia pathway, for example. The likely first one to be addressed within Leicestershire is going to be around supported living, for example, and technology can be used really well to help people in those circumstances, both for their own benefit and sometimes to huge financial benefit per user to the council, because these are people that you can change the profile of support they're receiving for their lives, depending on their age. So absolutely, the strategic development of the service is going to be an important part of our work with Leicestershire in the years to come. Mark, I'll stop wittering and hand to you.
Yeah, just a couple of comments on that, and I think you've actually hit the nail on the head about the purpose of these types of services. I think when we started looking at this, one of the things I was adamant about was that it isn't about the technology, it's about meeting people's needs, and that those points we were making earlier about the conversation with people are absolutely critical. If you go to talk to someone, you've described your mother, I've got a mother probably 10 years older, if in similar circumstances. So if I started talking to her about, it's a load of technology, it'll do this, she'll probably have a similar reaction. But if I started talking to her about, actually, this will help you if you have an emergency, if you're out and about and you get into a bit of trouble, you can just push this button and talk to somebody. They start to have meaning to people as opposed to it being technology. And I think that's really important. There are other elements of support that are really critical as well. So, for example, we've got a fairly well-established dementia pathway where we support people who've got that first diagnosis. And the really critical thing there isn't necessarily the person with the diagnosis. It could be more the person who's going to be supporting that individual. And it's about understanding the circumstances of those individuals, those families, those units, and using technology that's in a way that's very meaningful for them, but also couched in terms that are very meaningful for them. So I think you're right. The sort of developmental approach that we take in terms of using technology is all about how can it actually help meet particular challenges that we're beginning to identify. And how can technology have a role in supporting that, as opposed to we found a new piece of technology, what are we going to do? So I think you're right to be cautious in terms of having a non-tech focus in that sort of quite aggressive technology way. But I think you can be reassured that the approach that your colleagues are taking in terms of working with this and developing that is very much on the right lines in terms of making it personalised and relevant to the individuals who receive the service.
Thank you for that. And I'd like to say thank you for the presentation. I think we should move on at this point. We have quite a few items to get through this afternoon, but thank you to all for that. We now move on to item 9, which is also a presentation regarding the Leicester, Leicestershire and Rutland care record, as set out on pages 17 to 26 of the agenda pack, and which will also be displayed on screen. The Director will introduce this item before hand over to Stephen Pugh, Head of Service for Access and Digital, and Lorna Goldchalk, LLR's Care Record Programme Manager at the NHS, to present. Thank you.
I'll just slide the slides, shall I? Do you want me to slide the slides?
Yes.
Yeah. Yes, please.
So I'm just going to introduce very quickly and just introduce Laura and Steve. The report this afternoon is a result of a specific request by a committee. And we brought a report previously in January, I think, on digital developments, and committee asked for something a little bit more in depth in terms of the shared care record. So Laura's very kindly come along together with Steve just to provide that extra detail that committee asked for. Thank you. Is it Laura first?
No, it's me first.
Oh.
So, thank you. Our Leicestershire and Rutland care record is part of a national programme from the Department of Health and Social Care, known as the Shared Care Records Programme. And each integrated care system area has been tasked with creating a shared care record. And here in LLR, we've utilising the setup used by Yorkshire and Humberside for our system. And that's also not only an effective way for us to deliver the system, but it's also enabled us to tap into their learning and knowledge and their experience of setting it up. The shared care record is for use by health and social care professionals, those that are directly involved in an individual's care. And the aim is it gives them a holistic picture of the care and the treatment that they've received across the range of services. The integration is not sort of an old school integration of lots of complicated joining up and linking of systems. What it is, it's delivery of a simple to use viewer that collates the information across health and social care from multiple systems, but the data actually stays in your individual systems. So, for instance, here at Leicestershire, we'll have a viewer in our Liquid Logic Health and Social Care Records Management System. So a key objective here is to implement a single, secure, regional method to share data between health and social care systems in LLR for the purposes of direct care. And as I mentioned, that data will be practicable, usable, accessible and accurate. And another objective is to ensure the inclusion of social care information, and indeed this was mandated by the national programme. So having shared views of information provides us with a raft of measurable benefits to health and social care professionals, as well as people within LLR. So I'll now hand over to Laura. As John said, she's the programme manager, and she can explain more about it and the benefits and how the programme is developing.
Okay, hi everybody, I'm Laura Gottschalk. I'm the programme manager for the LLR Shared Care Record for our area. So I just wanted to introduce really what the LLR Care Record is. So currently hospitals, GPs and other health and social care providers record information in their own separate systems, which isn't always as easily shared as we would like it to be. This can cause care and treatment delays and organisations with having to forward important facts such as by phone or email or paper. The LLR Care Record actually pulls that data from lots of different health and social care systems to show information in one place for a person. It doesn't actually store any data itself though, and it will be enabled. It will enable the most up-to-date information to be available 24/7 to health and care professionals providing direct care for an individual. Professionals will be able to make better informed decisions that can help improve outcomes for those receiving care. So in practice, this could mean a doctor in hospital, for instance, or a paramedic who attends a 999 call will be able to access the same crucial information as a GP, such as details to allergies, current medications, bringing potentially life-saving benefits there. It will mean people being able to leave hospital with care staff confident that the right social care package is in place for them at home, and also that mental health and social care colleagues are able to better support someone in crisis. All records are strictly confidential and can only be accessed by the clinical and care staff who are involved directly in that person's care, and are accessible through our existing systems through something called contextual launch that we use. So they will use, say, Liquid Logic, but able to access that through a viewer through that system there. Data protection is also paramount. No information is passed on to third parties, and individuals do have the right to opt out if they wish by contacting their information governance lead of organisations involved in their care. So what does it look like? So this is, I appreciate it's just one screenshot of what it currently looks like, but let me just start by saying this is a test patient. It's not real life data on this image here, just an example to show you what it looks like. The blue demographics bar along the top there shows the person's details, has more information on the drop down arrow on the right hand side. There are summary boxes in the middle which hold sort of a quick view of information under those headers, including which organisations the information has come from. And there's a more detailed information can be seen when accessing the same sort of headers there on the left hand side. So you can click onto theirs and there's a lot more sort of granular detail in there for the healthcare professional there. Search functions, as you can see in that top left hand corner, won't be available. We've configured it so that if a health or care professional is accessing it through a contextual launch within their own system, they can't just go and search for another patient record within that or person's record. It's only accessible for the one that they have direct care with in the first instance. It's also fully auditable. We can see which records and what details professionals have had access to as well, should we need to look into that. It's also really easy to use and has a logical placement for those using or used to using clinical and care systems. And as health and care systems develop over time, we can look at adding what additional information departments might need and making that accessible in the LLR care record in order to provide better experience to those they are looking after. So some benefits, we've got a couple of slides here for benefits. So for our social care colleagues then, we're looking at time reductions are one of the main ones. Requests for data, both in health and social care colleagues, staff can then focus on providing care rather than hunting for information for the people they're looking after. More joined up care for health and social care professionals can make it quicker, more informed decisions, and working as multidisciplinary teams as a collective to provide the best care, looking at a holistic picture. Eliminating duplication of tasks, investigations and appointments, and staff have the right access to information at the right time as well. Reducing the possibility of unnecessary admissions to hospital. And there's a huge safety benefit, of course, around here around existing medical conditions, medications as well, and allergies. It could stop a person receiving a medication that has a contraindication for something else they may already be taking or might have an allergic reaction to or have taken before and it hasn't worked for them. Health and social care can provide care in the right place to the place that is right for the individual, knowing that they will have the most up-to-date information that they need at that particular time. Benefits for our people then. So we are ease of access to this information for those involved in their care will help prevent people having to repeat themselves each time they receive care at different organisations. Sharing information also improves overall care outcomes. Reducing the possibility of unnecessary admissions. We touched on that before with our staff side of things as well. But if someone was to need to go into hospital, having that package of care in place ready for them upon discharge will also help to improve those outcomes as well. If people need urgent care, they won't have to remember all their care details, medications, dosages or allergies. This will be accessible to those involved in their direct care at that point as well. Ultimately, the driver for better, safer care and treatment is sort of the heart of this programme, really. The current position we are in, let me just see if it's going to let me shift the screen over there. There we go. Yeah. So the position we're in at the moment, the system we're using here is based on one that's been advanced in Yorkshire, Humber, Coast and Vale already. As Steve said earlier, the system has received substantial public and patient engagement in Yorkshire and Humber as part of its development and ongoing development. Our LLR care record is very much in its infancy at the moment, but we are at the stage we're technically connected and we're fine-tuning the system before promoting it more widespread. We're pleased to be able to share our plans as part of a public and patient engagement approach, and we'll be shortly launching our public engagement piece as part of the programme. LLR has got a track record already of engaging with local populations and has received information previously on issues on how people get tired of having to repeat themselves over and over again when talking to different health and social care professionals. We have identified some teams to go live in early April as part of our live testing and clinical safety assurance, but we'll be looking to obviously go through all of that before launching to a wider audience there as well. Yes, so I think the last slide there is just how to contact sort of Tracy Ward there, the Assistant Director of Integration, Access and Prevention at Leicester County Council. But yeah, we're happy to answer any questions you might have on some of the slides you've seen today.
Thank you both for that presentation. Right now, open to questions. I think Ms. Broadley, you have a question? Thank you.
Thank you, Chair. I'm glad to hear that you've got safeguards in place on who can access and the fact that you can only access the person that you've gone in for rather than have a snoop around everybody else. You know, I think that gives people a bit of reassurance. But the details, obviously, you go to your GP, you have a conversation with him that you might want that conversation to be private, you know, that you don't want the details shared with others. Is there something in place that certain details can't be shared? You know, can you opt to say to your GP, this is confidential between you and me, sort of like a priest, you don't want it going out to everybody. Also, the input of the details is vital. You talked about medication and dosage and whatever. And again, I can only speak from myself, and I know that my husband has loads and loads of medication, but actually on his prescriptions there is a lot of medication still on his prescriptions that he doesn't actually take anymore. So it's vital that the details that are on there are correct, because if he went into hospital tomorrow, they'd be thinking he's taking 17, 18 medications when actually he's only taking 7. So is there some sort of system whereby the details that are put on are correct, or that the details can be updated? And the last thing is really the opt-out for any person that doesn't want to be on it. How easy is it for them to opt out? Thank you.
Thank you. Yeah, all absolutely valid queries there, and no doubt sort of items that people would want to know more information on. In terms of being able to sort of say to, say, your GP, the example that you gave of, you know, this part of me, my sort of what I'm about to tell you, I don't necessarily want on my record, that would probably, you wouldn't be able to break it down onto that sort of granular detail unless it was, I know the clinicians don't type in sort of into the records word for word information that people would necessarily give to them. There are a certain criteria list of things that won't be shared. There's things like HIV status, gender right reassignment status. I think there's a list of about 12 different things that across the patch nationally are not shared through a shared care records anyway. And I can help provide the information on what those lists of items are. But somebody will be able to sort of say, for instance, they might want their health information sharing, but not necessarily their social care information sharing, and they will have the ability to discuss that with their local sort of IG data privacy officers. We will be publishing as part of that public engagement piece how people can opt out and how that is managed. We will, as a LLR, as a collective, our IG organisations within each organisation has sort of created a process effectively of how that will be managed, and it gives sort of the people within LLR the ability to speak to any one of their health or social care organisations they're involved with, and they can sort of raise that with any of them. There isn't sort of one particular point. They can speak to any of the people that are involved in their health or social care to be able to stop sharing or object to that access being shared at all. And sorry, what was your other query that you had there?
It was about making sure that the details are correct.
Absolutely, yes, thank you. So yeah, an absolute key one. So as we said earlier, the shared care record is a platform showing information that is pulling from each of the organisation's current clinical systems. Now, it is up to the clinical and care staff to ensure the data in their local native systems is correct. It does have date fields associated with, say, a medication when it was issued and sort of the dosages and things. But I appreciate sort of there are going to be some people with some real complex health needs that might have multiple different medications on there. It will be up to the clinical staff that are issuing those to make sure that they are correct and up to date. The LLR care record will only show what is pulling from those systems, so it is reliant on the information being correct in those native systems.
Thank you for that. Just for clarity's sake, would it be possible that we could have those 12 items, the list, just to send out to committee members, just so they can have have a look through. Would that be possible, please?
Of course, yeah, they are part of the documents that each of the organisations have had originally, but I can send those through to you as well. Yep, no problem.
Thank you very much. Any further questions? Thank you with that then. Thank you very much both for that presentation. We shall now move on to the next. Sorry.
I just said thank you. Thank you, Chair.
Oh, okay, thank you. Move on to the next item, which is charging for social care and support policy, as set out in pages 27 to 86 of the agenda pack. The director will present this item. Alison French, service manager, and Mike Ellison, team manager, are also in attendance to assist in answering any questions. Thank you.
Thank you, Chair. I'm very pleased to have Alison and Mike alongside me, because this can get quite technical, I have to say. In summary, we bring a report today ahead of a report going to the County Council Cabinet for approval of some changes to the current charging policy, which has been in place since 2015. The County Council charges for care and support, or asks for contributions to care and support, alongside and in line with the care and support statutory guidance, which lays out the the foundations and the regulations that allow us to charge and tell us what we can and can't charge for. And paragraph 4 of the report today just goes through some detail around the discretion that local authorities have got in terms of its charging policy, but also talks about the sorts of factors that we would want to take into account when we consider how people should contribute to their care and support. So there's a number of factors there in terms of things like making sure that the charges are reasonable, that they are clear and transparent, that they're equitable, that they promote independence and well-being, person-centred and person-focused, that they're applied equally, and that they support both individuals in the longer term, but are also sustainable for the county council. Alongside the changes that we're making today, and part of the reason for the changes that we're making today is that there was a recent High Court review of a charging policy that was brought forward by Norfolk County Council. And that High Court judgment determined that in its policy that it brought forward, Norfolk County Council were being potentially discriminatory to certain people, particularly people with more severe disabilities. What it also did was it highlighted the need for all local authorities to review their charging policies, and we've reviewed our charging policy in light of that guidance, particularly around what's called the minimum income guarantee, which is the income that a person receiving care outside of a care home is left with after the charge has been applied, and the personal expenses allowance, which is the similar thing for people who receive care in a care home. So it's the amount of money that they have left to spend after charges have been applied. Those amounts are set, the minimum amount of the minimum income guarantee and the personal expenses allowance are set nationally by government. Government haven't increased them since 2015. And Leicestershire County Council has always followed the government guidance on those amounts. We are expecting that the government will announce an uplift this year as part of its charging reform. The government have indicated that they will increase the minimum income guarantee minimum amount and the personal expenses allowance minimum amount. And then their expectation is that that will increase every year then in line with inflation thereafter. So we would expect as part of this policy review that the County Council will do the same. So the proposals that we're bringing forward are that we continue to adopt the statutory amounts, which the government will set in April of each year. In doing so, we would also retain an appeals process so that if anybody felt that their charge for their care and support was unaffordable or unreasonable, that they could have that decision reviewed. That will be certainly within the policy. We've considered the Norfolk judgment, but we believe that our existing policy is fair and reasonable, particularly in light of the review of the minimum income guarantee and personal expenses allowance. The other area that we wanted to highlight to members was some additional review of the policy in respect to the energy crisis that people are facing currently, which obviously is going to be severe, and the government have recognised that, and paragraph 20 we just outline some of the actions that the government have taken to support individuals with their energy bills. One of the consequences of those actions, particularly around the council tax rebate, is that potentially if people have a rebate on council tax, that might, within our policy, mean that they would be eligible to pay more because they'd have more disposable income. They wouldn't be paying as much council tax, and therefore we could charge them more. That would seem to be completely unfair, and therefore we're making a recommendation that we disregard, within our charging assessment, we disregard any rebate on council tax or in support with council tax as a consequence of the energy crisis. And we're also bringing forward a proposal that we also disregard any compensatory payment that people might receive as a result of either the Windrush compensation scheme or the historical child abuse compensation scheme. So I think that probably covers most of the areas of the report, but as we said, we've got Mike and we've got Alison here. If there are any questions that people want to raise around the technical aspects of it, or around what that might mean in terms of individual financial assessment, Mike and Alison will be able to answer any questions.
Thank you for that. It's a question. I think, Mr. Champion, you have a question, please?
Thank you, Chair. Just want some more background on this deprivation of assets and how we assess that. So I guess where my concern is, if it was HMRC, if somebody wants to make a large payment to a family member, buy a house, that sort of thing, there's a 7-year period on inheritance tax, which that is gradually degraded. So people know where they stand on that. With this, I can't quite work out where they stand. So if somebody wanted to say, for instance, sell their house, their daughter sell their house, and they buy somewhere together with an annex so that they can care for that person, 6 months, a year down the line, they could start suffering from dementia. Another year or two, they could start needing care. Then there's good intentions of why they did that, and they could have lived for 10, 15 years with that relative. But are we not in a situation where we can, and that's what we wanted them to do, is to move in with family to look after them. Are we not in a situation where we can prevent people from doing something because they're worried that we're going to come and hit them with deprivation of assets? So when it comes to us assessing, is it come down to it's a clinical diagnosis of something, and when that happens is when you would take that assessment point? Otherwise, people will always be worrying, can I do this to help someone? How do we process
that? Yeah, it's what's called the deprivation of capital rule. So in the government statutory guidance, it sets out the key questions that we have to examine before you can decide that somebody's deprived themselves of capital, and therefore it impacts on their financial assessment. And they set out 2 key questions. One is, at the time of the thing that happened, the gifting or the purchasing or transferring of an asset, did the person have a reasonable expectation of the need for care and support? So if they're fit and well, in all of the rest respects, they might not have that expectation at that point. They also need to have a reasonable expectation of the need to contribute towards the cost of care and support. So they must have had the information from somewhere, either from having perhaps non-residential care in the past and then moving to residential care, something like that. So only if those 2 questions are satisfied could we make a finding of deprivation of capital. But you're right, there's no timescale like there is for inheritance tax rules. There's no 7-year rule.
Just come back, Chair. So do we have a system where people can ring in and ask? I mean, if someone's about to say take that step, do we have a system where they can ring in and ask and say, can you give us advice? Are we doing the correct thing? That kind of thing?
yes, they can ring in. And we also have our care funding booklet for residential, which commissioning staff will give out to them as well. And that sets out all the provisions around it. What you can't be absolutely sure is making a future decision. You can't say, well, if you do this in a year's time, it will be okay. It will depend what the circumstances are at that moment in time. And if people do a number of things over a period of time, we have to look at the situation on each. And so if you give £10,000 away 4 times during the year, you have to look at the first time, and then by the second or subsequent time, the circumstances might have changed.
You happy with that, Mr. Champion? Any further questions regarding this? Mr. Mayor, please. Thank you.
So it's going to be one of the biggest policies that are coming forward, this review. And I think a lot of people are going to be interested in if they're going to lose their house or not. And I think that's the one. But I just wanted to move on from that. I think that debate has been had, and we'll come back to it, no doubt. But what it is that if I'm a resident in Leicestershire, I want to know clearly how much I'm going to be charged. So is it we go through an assessment process, and in that assessment process, do we lay out, or do we give whoever is applying, saying actually if you're assessed X, these will be the charge. If you're assessed Y, this will be the charge, and if you're assessed as having Z, this will be the charge. And that's all accumulated. Is that something that we give people up front before the actual charge is tailored to them, or is it just standard bands? And I wasn't clear about that one on here. So if I fall in a certain percentage, I pay that band of care, or payment towards my care, I should say.
The financial assessment with there is 2 separate financial assessments, predominantly one for if you have care and support in your own home or in the community, and one if you have care and support in a residential setting. And then it gets a little bit more different, because if you're in a residential setting, you can have a different financial assessment for a short stay, or if you're in there permanent. So it's always difficult to establish what that financial assessment will be and what the outcome will be unless we know what the care and support is going to be. So when a care and support assessment is undertaken, so somebody contacts the council, they ask for care and support assessment, and it's determined that somebody requires care and support and it's best provided in their own home, then they can complete a financial form, either paper-based or through our online financial assessment tool. Turns out at the other end, we get it and we complete a financial assessment and send people a notification letter. So they don't fall into bands. It's purely based around the type of care you're going to get. And as I say, in residential, whether it's a short term, whether it's permanent, and also whether you own a property or whether you've got capital assets. So there's lots of different factors around that. Does that help any? Yeah.
My final one is, because it's so complex, or it can be so complex because people's assets are different, and it might take time for us to assess those assets. Is it going to delay somebody getting care? That was my final question.
It should never delay care. I mean, we can backdate. So if we get, we always say that somebody's care needs to take priority. So some people really want to know, and understandably so, what their financial assessment is going to be before they agree to care and support, and that's fine. But you know, if there is a delay in getting that financial information, because some people haven't got it to hand, you know, if you've got an elderly relative and you don't know where all the paperwork is, it can take a while for you to get all the paperwork together. So we complete a financial assessment when we've got all that paperwork. But the important thing is it can be backdated to the start of the service. So it could be 2, 3, 4 weeks, months, you know, depending on when we get the information for the financial assessment.
Brilliant. And then my final question is, the policy is all good and well if somebody reads it and takes it on board or whatever it is. But what we find now is, and we've talked about technology, is that actually people can do a lot of stuff themselves. So they can put in their assets, they can put in their savings, X, Y, and Z. Is there something that we can build in onto our website, like a calculator, to say actually, as a rough guide, if this is what you have and this is what you this will be your entitlement?
We have got an online financial assessment tool. It's currently on the website now. We are looking to improve it. What it actually gives at the end, because it's only as good as the information that somebody puts in. So what we're trying to ensure is that we're asking for the right information. So there's still quite a bit of work to do on the online financial assessment. But what comes out of it is it's an indication of what their financial assessment will be. And then when it comes through, if you press all the right buttons and it comes through into us, and we will only get it if there is a care and support service. So if they're eligible for a care and support service, and we check it. So, and then we'll send out the letter. But we are hoping that the online financial assessment tool is going to be used more widely, and we'll be making. We'll be doing a lot more publicity around that, so people are aware it's there. Okay.
Thank you.
Okay. Can I just add one thing, John? We have had the local authority circular with the amount. It's only recent, and it's 3.01% the increase.
You might just need to tell people what that means. Members won't be aware of what the MIG currently or what the PA currently is.
Right. Okay. So on the minimum income guarantee at the moment, it's as John said before, we've been having the statutory minimum since 2015. So what the government decided, a part of the charging reform, that they were going to increase it. We get something called a local authority circular, and we normally get that in February. We got it last week, Tuesday. And what they've said is that the increase in the minimum income guarantee amounts and the personal expense allowance amount is going up by 3.01%. So that will set the minimum statutory amounts. The personal expense allowance is a little bit easier to define because it's £24.90 currently. So it's 3.01% on top of that, which is 25.65. There you go. But the minimum income guarantee is slightly different because it's age related and disability related. There's quite a few factors to it. So I can't sit here and give you an amount, if you see what I mean. It really depends on quite a few things. But we did think it was a bit of a strange, because they didn't say, normally what they say is that it's in line with CPI but they didn't. They just says it's 3.01%. And we thought it was a little odd. I mean, it is worth mentioning because benefit increase has gone up by 3.1%. So we didn't know if it was a typo. Yeah. So, but that's what we've got. That's what we're working to, the 3.01%. Okay. Thank you.
Thank you for that. So with that, we shall note that report. Is there no further questions? Thank you. We now move on to item 11 regarding Leicestershire Adult Learning Services, as set out on page 87 to 138 of the agenda pack. The director will introduce this item before hand over to Nigel Thomas and Paul Fleming, Head of Services for Adult Learning, to present. Thank you.
Thank you, Chair. It's probably best that I hand straight over to Nigel, I think.
Thanks, John. So this report is providing the committee with an overview of Leicestershire Adult Learning Services, or LAL's, performance for 2021 within the context of an annual assessment, a service assessment that LAL's undertakes every year. But also this time we've had an external inspection or overview from with a view to potentially anticipating a further Ofsted inspection, which could happen at any time over, sort of the next year or so. Paragraph 2 just sets out the policy framework. All I will mention here is that LALS provides learning programmes which target vocational skills, basic skills and mental health. And in addition, it leads on the Work and Skills Leicestershire project, which is funded through the County Council, and that supports, it's a universal service that supports people seeking to regain employment. The service is externally funded, through the Adult Education Budget Grant, and that's administered by the Education Skills and Funding Agency, ESFA, or used to be the SFA. And the service can raise additional income through tuition fees and contracted services. So in effect, it's almost a provider of skills and community education. It does this, it provides part-time courses for adults 19 years plus across the county, and it delivers that across 50 venues, including the council's library services, employs around 300 staff, and pre-pandemic was attracting around 6,000 to 8,000 enrolments every year. If you look at paragraph 7, that really just outlines the strands of the programme split into adult skills, so things like skills for life, English and maths, personal development, family learning, languages for speakers, English for speakers of other languages and foreign languages, vocational skills, apprenticeships, and as I said, Work and Skills Leicestershire and the Kickstart programme, and high needs focusing on mental health, learning for independence. We were last, the service is regulated by Ofsted, as I've said. Our last inspection was back in 2018, hence we're thinking the time is right for another inspection. And at that point, we were rated as a good service, and the scale runs from inadequate requires improvement, good and outstanding. So we're in a strong position. And every year they do a self-assessment report. And as I said, we've had an external consultant look at validating the findings this year to make sure that we're on the right path and what further work that we might need to do. So just looking from paragraph 10 onwards, it talks a little bit about how LALS does that. It has a quality improvement plan for the whole service and its constituent curriculum areas. Tutors and learners contribute to that self-assessment report, and they do that through evaluations and surveys. So there are things like classroom observations of a tutor in action, and the tutors get feedback on that quality of learning. And any issues then are raised through a quality board that meets regularly. Appendix B in the report summarises that self-assessment against the Ofsted criteria. So when Ofsted do come, they will have a set number of criteria that they will look at. Just in terms of then the findings of that self-assessment, one of the first key things we look at is adults' achievement rates, and that means the number of learners who pass an exam as a percentage of those starting a course. So if you had 10 people start a course and 8 pass their exam, that's an achievement rate of 80%, as an example. And the table in paragraph 14 shows that in terms of that achievement rate, we're around 91% in 2018, 19, it then dipped a little bit, 19, 20, and then it's begun to go back up again of 2021, and you have to bear in mind that the COVID pandemic was going on through that, and that's fairly consistent with other providers of adult learning across the region and the country. But we do know that achievement rates for longer learning programmes such as English and Maths GCSEs have been more significantly affected. The next area from paragraph 17 looks at learner numbers, and as you might expect, because of the pandemic, we've seen that learner numbers declined by around about 45% last year, and certainly equivalent to 2018. But there are showing signs of recouping some of those numbers, and in fact, a learner recovery group has been established to really provide a focus on what do we do to bring learners back. LALS did a lot of work during the pandemic. It provided a lot of provision online, but clearly, obviously you can understand that people were quite wary of going into classrooms, or they couldn't, certainly during the height of lockdown. Paragraph 18 looks at the courses delivered and the average class size, and you can see from that chart on paragraph 18 that the number of courses delivered dropped a little bit from 1920 to 2021 and has begun to recover following the pandemic. But the average class size is sort of relatively stable at that lower level of around 5% from its peak in 1920 of 7%. Paragraph 19 looks at the feedback from learners, and you can see there very high rates of satisfaction or people agreeing or strongly agreeing with a number of statements there. And in terms of safeguarding, our policies and procedures are deemed to be robust, and learners report that they do feel safe in their end of course reviews. And we've got well-established procedures to identify, report and respond to any safeguarding concerns. So said that in November 21, we engaged with a consultant, current Ofsted inspector. Didn't do a full inspection, obviously, that when that happens as a team of people, but he did look at, we did ask him to validate what we felt on our self-assessment, what the outcome of that was. And paragraph 24 looks at some of the main findings of that validation. Says things like managers and leaders have constructed a curriculum which does meet the needs of learners and local stakeholders, and that managers have a good understanding of how the curriculum aligns with the service strategic ambitions. And also there's a lot of effective engagement with local partners, and there's sort of examples there. In terms of the specific recommendations, there's a list of those in paragraph 25. I'll pick out a couple of things there. We do need to look at some inconsistency in the quality of the self-assessment report and the quality improvement plans themselves. And it was recommended that the service ensures that the improvement plans are reviewed regularly in line with the service's quality calendar to harness the will and accountability of all staff in driving improvement. And also it's very important that we use forums such as this and ongoing briefing of obviously our lead members so that they're kept regularly aware of the sort of quality aspects of LALS as part of that overall governance. And that's the sort of thing that they would look at when the team come in to do their Ofsted inspection. Also, lastly there, that we should ensure that all programme managers are able to articulate the strengths and weaknesses of their provision and the quality of the various aspects of implementation across teaching, learning and assessment, so that it can be clear about how we manage our service areas onto the next step, hopefully, of continually moving towards an outstanding grade. So that's pretty much all I was going to say by way of outlining the paper. Paul is here to answer the more technical questions around adult learning, but happy to take any comments and questions at this point.
Thank you for that. Just got one question. I spent many a year with our Ofsted friends as a school governor. How far off from outstanding do you think you are? See, there's lots of twos in there. Are we close or are we middle? Just for clarity on that, if possible, please.
Yeah, I'll ask Paul to cover that, but I think it is a mixture. There are some areas where we're a solid 2, but there are some areas, parts of the programme that are actually outstanding. And obviously that's what we seek to build on, but Paul probably will be able to tell you a bit more detail about that.
Yes, I think that's exactly right. In terms of the curriculum overall, there are strong areas. The apprenticeship programme's doing very well with achievement rates above the national average. And we're really looking for to be around 10% above the national average to get into that outstanding window. There are some of the longer programmes that I think have suffered a bit more during the pandemic. There's mentioned in the report around Skills for Life, that's English and maths provision. So there's a bit more work to do there. and I think over the next year that will certainly be a focus for us to achieve an overall outstanding rating. If you've had some experience with Ofsted, it it requires across the board sort of outstanding grades, particularly around achievement rates.
Thank you for that. Miss Broadley, you have a question, please?
It's not actually a question. I might have I might have had to declare an interest in this. My daughter works at the Symington building in Wigston Library and facilitates these classes. I thought it was education. So if that's what all this is, because it's not, she does languages and different things. She doesn't tutor, she facilitates the thing, working for Leicestershire County Council. So if that's what this is, please can I declare an interest? Sorry.
Thank you for that. That interest has been noted. Any further questions, Mr. Mayor, please? Thank you.
Cheers. Thank you, Chair. I just want to say this is a very important service out there in the community. I think we have been impacted by COVID. It'd be nice to see the numbers bounce back up so we can get that service provided, because background ESOL. So ESOL was very important in my community in Loughborough East because a lot of people have English as their second language, but it's just not that. A lot of them are, I hate to say it, but illiterate, so they can't read and can't do maths as well. So it's very important that we do get out in the community. It just improves their life chances, and that's what it's all about, I think. Yes, it's confidence in speaking English, but it's improving their life chances and also being able to communicate with their children who go to school full time and pretty much speak English really well. And I think this is the value of the service, and I think the more we do it, the better our communities are going to be. Thank you.
Thank you for that. Any further questions? Right, with that, thank you very much. We shall note that report. Thank you. Right, so the final standing item on today's agenda on the use of resources in adult social care, as set out on page 239 to 214 of the agenda pack. And once again, the director will present this item at the last time. Thank you.
Thank you. Yes, I will present this one. So this is the second report I think we brought to committee on a national report that comes out every year. Well, every year, it's been produced for the last 3 years by the Local Government Association, which compares expenditure and activity across all local authorities. Just before we get into the details, just worth noting the caveats that are sort of paragraph 7 through to 10, which just note that it is difficult to compare authorities on a like-for-like basis because for a number of reasons. First one is that although we have kind of national data collection, national reporting requirements, different authorities do report slightly differently in different ways. So that does mean that it can be a little bit tricky to compare. The other thing to say is that obviously this report relates to 2020-21, which obviously was impacted by the pandemic. And that's had a big and significant impact on the data that was contained in the national reports. Although every local authority was obviously experienced the pandemic, our responses to it and the way that we allocated resources to the pandemic is slightly different across the piece. So again, that does create some complications. And it's just probably worth looking at the data that's in the report as a means of understanding the Leicestershire position and where Leicestershire needs to improve, rather than a direct kind of comparison between Leicestershire and another council, for example. But it's a useful report because in terms of being able to kind of highlight what those sort of questions might be and what the challenges that we face might be. So with those caveats, just go into some of the detail. Paragraph 11 starts to talk about expenditure, and it notes that Leicestershire had the 13th lowest expenditure on adult social care per adult, And by that we mean if you take the total amount that we spend on adult social care and divide it by the total number of adults in Leicestershire, you get a figure, and do the same for every other authority. And what you see is that we have the 13th lowest expenditure, because that's in the context of Leicestershire having the lowest spending power of any council in the country. So you would expect that we would be in a position where we would be spending less than others who are funded to a higher degree. In terms of long-term and short-term care, so by long-term care we mean people in care homes, people who have long-term domiciliary support. Short-term care, we're thinking about things like temporary placements in care homes or reablement activity, short-term interventions. What you'll see there is that out of 151 councils, we were ranked 144 for long-term care in terms of our expenditure, so 151 being the lowest, and 93rd for short-term care. So what that kind of tells you a little bit is that we proportionally spend more of our budget on short-term care than we do on long-term care. So paragraph 12 talks about older adults in particular, and we're just noting there that we spend 35% less than other councils in the East Midlands and 26% less than other Shire counties on older adults. And similarly, for working age adults, we spend between 22 and 24% less than other councils. So what does that mean in monetary terms? Paragraph 15 looks at the total amount that we spend divided by the total number of people that we serve, as opposed to the total number of adults in the county. So what that gives you is it allows you to have a figure, a financial figure, which kind of perhaps makes a bit more sense to people. So if you look at that paragraph 15, you'll see that for people of a working age, we're ranked 106 out of 152, and we spend on average £24,000 per person that we serve, compared to 27,000 across the region and 31,000 in other Shire areas. And for older adults over 65 years, we spend on average £10,000 per person, per individual, compared to £14,000 or £16,000 respectively for regional and nearest neighbour authorities. So that gives you an indication of the amounts that we're spending on individuals compared to others. In terms of the overall demand, we have a slightly higher number of requests for support than perhaps other councils do. One of the things that is starkly different is that of those new requests for support, there appears to be a much higher number of people in Leicestershire who go on to receive no service compared to the number of people who were signposted to other services. We're doing some analysis now on that. And what we want to understand is whether in fact that is a real significant difference, or whether it's just a difference in recording practice. So are we recording lots of people going on to receive no further services who actually do get signposted to other areas but don't get anything from us? Or actually, are we not signposting people in the way we should be? Is the question that we need to answer, I think. So we're doing some further work on that. There's also then paragraphs 18 through to 21. There are 4 areas where indicators where there's a comparison in terms of how councils promote people's independence. And as you'll see on those 4 indicators, Leicestershire fares comparatively well. So the first one is direct payments, people who get a direct payment. 42% of people in Leicestershire who receive a community service have a direct payment, and that places us 6th out of the 152, where, and in this case, 1 is high. It changes depending on the indicators you have to watch. So we do fairly well on that one. In terms of people with learning disability in settled accommodation, again, we're in the top third of all authorities. And in terms of people who go on to receive permanent residential care, again, we're 130th out of 151, where 151 is good on this particular indicator. So we're in the top quartile for that one, and we're in the top quartile. In fact, we're the third highest council in terms of younger adults going on to receive permanent accommodation. So we, in those indicators, we do fairly well. In terms of cost of care is an interesting one, because you might imagine that if we spend less on delivering services to people, that perhaps one of the reasons for that is that we don't pay providers the same amount, that perhaps we're not paying a fair cost for care. But actually what paragraphs 23 to 25 show is that across both domiciliary care and residential care, Leicestershire is a comparatively pays a high rate for care, so more than the average council. So we're in certainly the top quartile for home care, and round about sort of second quartile middling for residential and nursing care. So we've then provided a little bit of analysis in terms of why those figures might be as they are. Talked about the fact that we're a low funding authority, and therefore you'd expect that there would be a lower amount of funding on adult social care, as there would be for other services in Leicestershire. If you look at the overall amount that we spend, I think we're spending about 39% of the total council budget on adult social care, and that's certainly consistent with what you'd expect to see in a county council. Other factors that impact things like the number of people in terms of demography. So we often think about Leicestershire as being a council where, in a county where there is an ageing population, and there is. And certainly when you look at Leicestershire against regional comparators, that might have an influence. So you'd expect, for example, there to be more older adults receiving care in Leicestershire than in, say, Leicester City, proportionally, because we have a higher proportion of older adults in the population. If you look at us compared to other shire counties, actually, we're not an outlier at all in that respect. So, in fact, we've got slightly less older people than would be the case for other shire counties. Deprivation also has an impact, particularly on older adults services. So if you have higher levels of deprivation, it's likely that you would have more people being supported by a council in terms of social care. The more affluent the council area is, the higher the number of people funding their own care. That will have an impact. So the fact that Leicestershire is a fairly affluent county does mean that you would expect that there would be fewer people receiving care in Leicestershire than in other areas where there are higher levels of deprivation. But that's not that only works for older adults. It doesn't follow through for working age adults at all, because you have very many fewer working age adults who have got any capital asset built up, and therefore they wouldn't be paying for their own care. Yes, they wouldn't be paying for their own care in the same way. The fact that our spend per client is higher than our spend per person does suggest that we are providing people with a level of service that's commensurate with need. So what we are doing is we are assessing people, we are determining eligibility, and we are providing services for people who are eligible. But what we are providing is a lower level of personal budget overall for those people. So we're providing the right people with care, but we're providing a lower level of expenditure than other authorities do on the same people, on that cohort of people. The number of people who receive short-term care is comparatively high compared to other authorities. And it appears that we have a higher turnover of clients than do other authorities. So what we're seeing is a pattern of a number of people receiving short-term packages of care. And some of those people may receive more than one short-term package of care, as opposed to the pattern of care in other authorities, which is that people would receive a package of care and get it forever. So what we try and do is we try and promote people's independence through reablement and other services to the point where they can be more independent, but it might then be that they come back at a later date when there's another crisis that's hit or when they've had an episode of ill health, and we provide another short-term package of care. What else do we want to say? As I said, we're looking at the front door process, and particularly in terms of how effective we are at managing demand. And we've just, in fact, had a peer review led by director in another East Midlands region, and with colleagues coming from 3 or 4 different East Midlands authorities last week to look at how our customer service centre operates and how our front door information, advice and guidance services operate. So once we've got the feedback from that, that'll help us to consider that question about whether or not we are signposting people in the right way, and whether or not people are getting the service that they should do when they contact the authority. Direct payments, we've already said, is an area where we have a very high number of people with direct payment, receiving direct payments, and therefore managing their own care. What we have seen is, and we did a piece of work earlier this year, a survey earlier this year, which demonstrated that people who receive a direct payment have very high levels of satisfaction with their care. Higher levels probably than people who receive a managed service. But what it also showed was that the process, the direct payment process itself, and the process that we go through to set up a direct payment is extremely complicated, and that does put people off receiving that service. So I think there's something we need to think about there as well in terms of making that a simpler process for people. And then I think it's probably worth just noting finally, paragraph 1441, just note that given the significant demand that we have experienced over the course of the last 2 years, and the significant amount of growth that the council is now allocating to adult social care services through the MTFS, it is likely that that position, if we run this report forward 2 years, which is when we'll get the report on the 22-23 expenditure, it's likely that that position will have changed somewhat in terms of our relative position to others, because we are making a significant allocation of resource into adult social care, which will probably be above and beyond the amount that's being allocated by other authorities. So that position may well change over the course of the next 2 years. And I think that's probably all I need to say. Thank you, Chair.
Thank you for that report. So, but I'll take from that we're in the bottom 25 for spend and in the top 25% mostly for the care we actually give, is the way I can understand that, which I think looks very good to me. Any questions? Sorry, Ms. Champion first, and you, Mrs. Broadie.
Thank you, Chair. I appreciate what you say, John, when you can't compare in the figures, but the one that just stuck out to me is page 195 of the report, which is the local unit costs. And we've got our average hourly rate of 61.79, with the average at 19.10. There's such a huge disparity there. I just wonder if you could clarify that a little.
Yes, certainly, and it's heartwarming to see that you actually read the detail in the report. So what you've got there is the hourly rate that's quoted there is for the internal service, home care internal service, the £61. What they mean by internal services, essentially it's our reablement service. And the reason why the costs are so high is the way that we account for it. So when we account for our reablement services, we're not just counting the reablement workers, the home care workers who go out every day and work with individuals. We're also counting all of the occupational therapy services that we have within the authority. They get counted into that. So that's the professional occupational therapists. We also count in our crisis response service, and we also count in all of our overhead management costs. Now that is something that we probably need to look at in terms of how we account for that service, because other authorities don't do that. They just count the home care workers who go out and deliver the home care service, which is why it looks like we've got £60 per hour and other authorities have got £19 per hour. So we do need to look at that in terms of how it's accounted, because it does look a bit odd, doesn't it?
Yeah, that was Champion. Thank you. That was Broadley.
Thank you. Direct payments. We have more people on direct payments than other authorities, but then you went on to say how complicated the form is, and I agree, it's very complicated. If we are going to streamline it and make it easier, do you anticipate that the levels will go up even higher then?
I would hope that the levels wouldn't go down. And what we have seen over the last 2 or 3 years is we've got 42% now, I think it quotes in the report. At the high point, we had 45%. So it has gone down slightly over the last few years. It's gone down particularly in older adults, people over 65. So we are still seeing quite an uptake of working age adults, of families being able to manage that direct payment on people's behalf. But obviously for older adults, that's maybe not quite so much the case. So I am hopeful that it will either stabilise or it will go up if we can simplify the process. Part of the problem we've got is that obviously when we talk about direct payments, we're effectively giving cash to people to buy their own care, and therefore we want to make sure that people are safe and that the care is the right care, but we also want to make sure that the council's money is being used appropriately. And it therefore requires quite a lot of audit work, which is where the complications come in. But sometimes there's always ways to simplify a process, I think. We should always look to do that. And it's making it simpler for the person at the receiving end, even if it means that we've got to do something else in the back office. That's sort of the swan scenario, isn't it? The person receiving the service doesn't notice, but we're doing lots of work in the back office to do that audit and the safeguarding elements of it. But yeah, it is an intensely complicated process. I understand why people don't take it up.
With that. Okay, Mr. Mayor, please. Thank you.
Thank you, Chair. John, if you came to us with this report and said, actually, we spend as much as other authorities on care, but our back office system is streamlined and ultra efficient, that's why we don't spend as much on as a total on care. But actually, if you look at page 157, and we only spend 66% on care, on age 65 care as the total for England. And still, when you look comparative to our neighbouring councils and comparative authorities, we're much, stingier at spending on care. It's not a good report. If I was a Leicestershire resident reading it, I'd be thinking my council's shortchanging me because other councils are spending far more on their care. And I know we provide excellent care, and I think we do. Officers work hard to provide excellent care, but when you're spending 20-30% less money on Leicestershire residents as other authorities are spending, then something has to, somebody will say, actually, we're not getting value for money, we're not getting the services that we're paying our council tax for. And nowhere in this report does it mitigate the fact that, we are spending, the gap is so large. You've tried to say it in your report and said all the other things that we do and all the differences in there, but unfortunately, this is what happens in 10 years of austerity and not getting funded properly, is that we cut away services, and then when reports such as this come to us and we see how much other authorities are spending on care, we're not spending near enough as we should be, or providing enough care as we should be. Because if we did, if that extra £200 or £300 per person was being spent, we'd have such a good care service, but we don't have that at the moment because we can't spend the money on it. And I don't want to be any more critical, because I think that's not fair on officers, and that's not to yourselves. I think you get a direction, a political direction, on what to spend the money on. But a gap of 33% or 34% is massive, massive in anybody's book. Yeah, so I think Leicestershire residents are getting shortchanged, honestly. You know, reading this report, I've never seen it before like this. But yeah, so that's just my comment. It's not even a question, but I think we're getting shortchanged.
So I just want to clarify there. I know what you've just been saying, but am I correct that our percentage of the budget on adult social care is equivalent to other authorities? Can I just have a clarification on that, just to answer back to Mr. Mayor, please?
Yeah, so the proportion of the council's total budget that it spends on adult social care is consistent with the amount that you would expect of a Shire county. So if you compare us with the SIP for nearest neighbour group, then you would see that the amount that we spend is about 39% of the total budget for the council spent on adult social care, and that would be true of all Shire authorities. It differs, that percentage differs for unitary authorities, because obviously they have a different basket of services that they provide. But for Shire counties and for two-tier county councils, yeah, it's a similar amount.
Thank you for that, Joe. Just to clarify, so we are actually equivalent to all other authorities. Any further questions from anybody regarding this, please? Well, okay, I'd like to say thank you then. So close that one down. So item 13 will be the date of the next meeting, which is the 6th of June 2022 at 2 p.m. Item 14, any other items which the Chairman has decided to take as urgent. And as before, there are no urgent items. So I'd like to say thank you to all the officers and everyone who's presented today. Thank you for attending today's meeting. I now declare the meeting closed. Thank you.